with the Global Community Health Sciences, Community Health and Behavioral Sciences Department. Dr. Moses utilizes methods from epidemiology and ecology to understand the interface of animal, human, and pathogen origins. In addition to observational and quasi-experimental field studies, she is interested in implementing human and animal surveillance for zoonosis at the community level. She is overseeing district-wide serosurveys, community prevention interventions, case investigations, and contact tracing, observational, epidemiological, and ecological studies, partnered with the Kinema Hospital Ecology Community Outreach Teams as part of the Ebola virus disease outbreak in 2014. And she's also served with Tulane's Lassa fever program in the area. Dr. Moses has over 70 peer-reviewed publications and has been cited in excess of 3,700 times, and was a key principal in the PBS spillover broadcast entitled Spillover, Zika, Ebola, and Beyond. So it's my distinct pleasure to introduce these and turn it over to these expert guest speakers. I will stop sharing my screen, and Dr. Wilson, it is all yours. I believe you are up first.
Okay. So hopefully everyone can see my screen. Thank you for attending and giving me the opportunity to talk to you today. And I would like to begin by just briefly introducing what industrial hygiene is, because oftentimes when I tell people that I'm an industrial hygienist, I get met with a confused gaze of, well, what exactly does that mean? So industrial hygiene is something that operates in the background of pretty much all of our workspaces. We are primarily within departments of occupational and environmental health and safety. And our field is broadly defined as both the art and science of the anticipation, recognition, evaluation, and control of hazards in the workplace. And the hazards that we focus on are quite varied, right? They're basically anything that can be problematic in terms of health outcomes in occupational settings. So that includes biological hazards, that includes chemical hazards, as well as physical hazards like noise and heat stress, and ergonomic and psychosocial factors as well. So we have traditionally, as a discipline, operated in kind of a compliance role, where we are responsible for evaluating exposure scenarios in terms of how they reconcile with things like OSHA permissible exposure limits, or NIOSH recommended exposure limits, or ACGIH threshold limit values. And those are the kind of things that you run into if you review a safety data sheet for an individual chemical. We also have credentialing agencies through the American Board of Industrial Hygiene, which provides the Certified Industrial Hygienist credential, or the CIH, which denotes that someone who has that credential is properly educated and trained in the art and science of effectively keeping people safe at work. And we also have a very active professional society, the American Industrial Hygiene Association, that is an excellent resource for occupational health and safety information associated with all kinds of workplace hazards. So not just infection control and biological hazards, although that is going to be the focus of our talk today. There is a massive amount of information associated with hazard recognition and mitigation in occupational settings that already exists. So when we operate in our field, we do it based on this framework, right? So this figure gives us two different ways of looking at the anticipation, recognition, evaluation, and control of hazards in the workplace. One of which on the bottom is kind of this linear enterprise where we are evaluating environments and identifying various types of hazards. and then conducting exposure assessments for those specific hazards, and then implementing control strategies to figure out how to deal with the exposures. So realistically, this is not a linear enterprise. It is much more conceptually thought of as a cycle. So it is continually something that is reevaluated to confirm that people are actually being protected from exposures in the occupational setting. So traditionally, industrial hygiene has focused very heavily on chemical exposures. But in light of the pandemic, one thing that occupational health professionals have been tasked with is to move more into the realm of biosafety and infection control. So there has been a limited focus on biosafety in industrial hygiene, but it has primarily been focused on biological hazards that exist in the environment. So things like Legionella in ventilation systems or mold in indoor environments. So the infection control component associated with industrial hygiene practice is something that's pretty new, but it's also something that we're actually pretty well prepared to deal with. And one of the main frameworks that we have to mitigate exposures is this idea of the hierarchy of controls. And the hierarchy of controls is basically giving us in order of preference, control strategies that we should try to implement to deal with specific exposure and hazard scenarios. So if we can, we want to eliminate the hazard from the environment. And in some occupational settings where we're dealing with chemicals or maybe noise exposures, that's something that we can functionally do. But when we're talking about a infectious disease, the elimination of that hazard is not something that we can actually physically control. Substitution is also something that we like to do in occupational health, where we replace a toxic material with a less toxic material. But that also is not something that's available to us in terms of biosafety. But when we get down into engineering control, these are things that we have available to assist us with exposure mitigation for biohazards. And we like engineering controls a good bit because they are things like ventilation or isolation, which engineer the environment in such a way that exposures are either eliminated or are mitigated to the point that they are not likely to be associated with health effects. So we like engineering controls because they engineer the environment in a way that's going to work whether people are in that environment or not. We also like administrative controls, which are effectively policy-based personnel management strategies that have direct consequences associated with exposure potential. So administrative controls are not modifying the environment. They're modifying how people interact with the environment. So policies that can mitigate exposures that people have a good frame of reference for are things like if you see a sign in an industrial site that says hearing protection required beyond this point, or hard hat area. Those are administrative controls that are policy-based, that are dictating that people use personal protective equipment. Now, personal protective equipment is a major part of exposure mitigation, but it's also the least preferred methodology that we apply in modern occupational health practice. So personal protective equipment is something that's going to supply a functional barrier between an exposure in the environment and a receptor. individual person. And if that barrier fails, then the exposure occurs. And then sometimes we also have issues with personal protective equipment compliance that can be problematic in terms of exposure mitigation. So people can just choose not to wear their respirators, and that can be really problematic. But when we think of PPE, we have to recognize that a lot of times we conceive of it as really focused on respiratory protection, but it's also things like dermal or cutaneous protection, so gloves and coveralls, or injury protection, things like eyewear or splash shields. So the hierarchy of controls has canonically very heavily focused on hazards. And in recent years, we have moved away from this really hazard-focused approach into this idea of total worker health, where we're not only evaluating hazards in the environment and assessing exposures, but we're also evaluating the holistic experience of how individual workers interact with their occupational environments. So we can apply the hierarchy of controls to this framework as well. And here we can actually eliminate exposure potentials, because for things like infectious disease, we can telework, we can not gather. And that is a very, very effective exposure mitigation strategy because it provides physical distance between potential receptors. We can also have high vaccination rates, which provide immunity that is very, very effective public health strategy in general for infectious and communicable disease. We still can't really substitute anything here because we're dealing with an infectious microorganism, but we certainly can apply engineering control principles to redesign work environments to mitigate exposures. We can also focus on educating workers associated with compliance with personal protective equipment policies, and also educate them on the differences in things like personal protective equipment and community protective equipment, which is something that we'll bring up a little bit later. So in the case of SARS-CoV-2, this is kind of a new area for a lot of people who are in industrial hygiene practice, because we're used to dealing with exposures in terms of workers being the receptor, but we're not typically evaluating environments where workers are also the source of the exposure, or other people are also the source of the exposure. So that's a unique thing. But when we're dealing with something like SARS-CoV-2, if we do a hazard evaluation, the hazard that we're concerned about is the infectious microbiological agent. The route of exposure that we're primarily concerned about is aerosolization and inhalation. So the hazard in the environment is this specific microorganism, but it's entrained in the environment as an aerosol. And aerosol exposure mitigation is something that we have a lot of experience dealing with in occupational health settings. So just to give you a good example of that, what do welding fumes, chromic acid mists, and respiratory bioaerosols have in common? Well, they all are very, very different from a mechanistic point of view in terms of how they may impact health. But they're all aerosols. Right? They're all tiny little particles that are suspended in the air that can enter our respiratory system and cause health problems. So for all of them, the primary route of concern is inhalation. And for all of them, the hazard is entrained in the environment as an aerosol. And if we want to mitigate exposure to that hazard, we have to mitigate exposure to the aerosols. So we have aerosol mitigation strategies that are available to us as part of just core practices in occupational health that are things like dilution ventilation or local exhaust ventilation or isolation of individual people so that they are not exposed to aerosols. And last but not least, we also have a good amount of information associated with how personal protective equipment allows us to mitigate exposure potential. So I really like this picture because it demonstrates, this is somebody welding in a confined space. And one of the best ways that you can deal with the welding fume aerosol exposure is to bring fresh air in front of the worker and have it clear the hazard from the breathing zone and then be exhausted back and above the breathing zone of the worker. So irrespective of the aerosol that we're talking about, that kind of environmental modulation is an extremely effective exposure mitigation strategy. So I just want to bring up the idea of the epidemiologic triad because a lot of people in the clinical realm have some experience with epidemiology in terms of their didactic training or their personal experience. So the epidemiologic triangle is just a framework that allows us to evaluate how we could develop interventions to deal with infectious and communicable disease. And where we focus in environmental and occupational health is in this leg of that triad. So if we break any one of these individual legs, we break the opportunity for the disease to propagate within a population. Another way that that's commonly conceived of in the clinical space is the chain of infection. So this figure came from this manuscript in Toxicology and Industrial Health, which is an excellent manuscript associated with dealing with COVID-19 within the framework of traditional occupational health methodologies. So if you're interested in reading it, I would encourage you to do so. But there are various ways in which we can mitigate exposure potentials at some of the individual links of the chain of infection here. So if we think about source controls, this can be as simple as fabric face masks, right? Which mitigate exposure potential to other people by decreasing the amount of respiratory aerosols that people are exhaling when they're breathing and talking and things. So we also know that things like vaccination can significantly help us with host susceptibility and the existence of reservoirs. So we are the reservoir for COVID-19. So we can break the chain of infection with that kind of intervention. But from an occupational health point of view, we really focus on this area in the mode of transmission. And one of the primary ways that we do that is by modulating the ventilation in indoor environments. So oftentimes you hear of air change rates. And that's something that is sometimes kind of conceptually difficult for people to wrap their head around. Is what exactly does an air change rate mean? And basically that means that the volume of air in a specific area is being flushed out and replaced with fresh new air over some period of time. And if you have air changes that you can increase, you can increase the number of air changes based on modulating the ventilation rates, you can effectively dilute contaminants in indoor environments. So we can conceptualize as air changes as a way to dilute hazards in the environment. And oftentimes in environmental health, we have a kind of axiom that the solution to pollution is dilution. And that's very much true in terms of dealing with hazards in airborne scenarios in indoor environments. performance. So in healthcare facilities and healthcare settings, we have the ANSI ASHRAE standard 170, which specifies the minimum outdoor air change rate for specific types of clinical enterprises, and also denotes a minimum total air change rate. So you can see here that it ranges anywhere from 6 on up to about 12, depending on the type of healthcare area that we're dealing with. So these are designed to mitigate exposure potential, especially in things like isolation rooms, by definition. So we also need to think about air change rates in facilities that are not in healthcare settings. Because if we're thinking about mass vaccination sites, oftentimes those aren't going to be healthcare facilities. They're not going to be clinics. They're not going to be hospitals. They're going to be things like perhaps schools or office buildings or sports arenas. And it is very beneficial to be able to evaluate the air change rates associated with those facilities. And there is, in fact, an ASHRAE standard, which is 62.1, associated with air change rates in non-healthcare settings, which is just ventilation for acceptable indoor air quality. And if you compare these air change rates to the ones for hospitals, you can see that homes, offices, and retail establishments are not designed to have air change rates above 3 per hour. But many places like schools, sports facilities, and restaurants are in fact designed to operate at least with an equivalent range of the low end of the healthcare facilities. So if we're evaluating the potential for using a specific space for a mass vaccination site, we can use the design criteria spelled out in the ASHRAE standards to give us a jumping off point to understand what the ventilation system in that space is likely to be able to supply. So we also need to recognize that we can physically evaluate the performance of ventilation systems, and that some of them are better than others. So we have this idea of this just kind of vocabulary, design occupancy, where a ventilation rate for a specific indoor area is set based on maximum occupancy of that area, and it never changes. And then we have demand controlled ventilation, where the ventilation rate is effectively averaged for the number of people that are in that space at a given point in time. So this is less energy efficient, but much more protective of health, because if you have a lower number of people than the maximum occupancy, your ventilation rate is not going to change. So I do want to point out on these first two panels that we have an inlet that is placed high in the room and an exhaust that is high in the room as well. And that is okay and will provide complete mixing of air within that room, but it's much better to apply principles that are going to allow us to push fresh air in across the breathing zone of potential workers and then be exhausted out above those workers. So we can also potentially do things like bring in local ventilation systems that allow us to isolate exposure potentials based on where we place those ventilation systems. So we also have things called local exhaust ventilation. And this is something that we use a whole lot for chemical safety. And it typically consists of capture hoods that isolate a source of exposure from a potential receptor. So these are things like receiving hoods, canopy hoods, that allow us to exhaust away that hazard from the environment. And they're designed to operate at a very specific capture velocity based on the hazard that they're trying to deal with. So we can design local exhaust ventilation systems to operate at capture velocities that are going to be very efficient at dealing with respiratory aerosols and respiratory droplets. And in fact, that's something that has been done. So this is a figure that comes from the expedient airborne infection isolation example from the NIOSH engineering controls database. And here we have a model of a patient room in which the headboard has been modified to become a capture hood. And this study was not carried out with microorganisms. This study was carried out with 1.6 micron polystyrene latex beads. And that really illustrates the point that all aerosols can be kind of conceptualized in the same way. And that if you can deal with exposure to a respirable aerosol particle, that you can use that model to deal with other respirable aerosol particles. So here you have the breathing zone of a potential source that is in a capture hood that gets fed into a HEPA filter, thus mitigating the exposure to anybody else in this area. We also have an example in which 2 beds are isolated with floor to ceiling plastic curtains. And this is something that actually would be quite useful in a mass vaccination scenario, where you can just have a station where someone may be vaccinated and then wait for some period of time to make sure that they're not going to react in a negative way, where you pull air through a hole in the front of the curtain past that individual and then exhaust that air into a HEPA filtration unit behind the individual. And this is something that could be easily daisy chained to mitigate aerosol exposure potentials. And again, this is something that is in the engineering controls database from NIOSH as well. So I really want to use this as an opportunity to point out that there are lots of different ways that we have to mitigate exposure. So we also have administrative controls, which are things like teleworking, social distancing, requiring fabric face masks for people, and having basic hygiene policies like requiring people to use hand sanitizers. And we also, last but not least, have personal protective equipment. And in the COVID pandemic, we have community protective equipment as well. And it's really important for people who are thinking about infection control to know the difference between community protective equipment and actual personal protective equipment. So personal protective equipment is specialized equipment that is designed to prevent specific exposures. And typically speaking, in occupational settings, users of personal protective equipment need to be qualitatively and quantitatively fit tested for that personal protective equipment. And they need to be trained specifically in the donning and doffing or taking on and off of that material. So this personal protective equipment in occupational settings serves as source control. So if someone is wearing PPE and they're infected, they're not going to spread respiratory aerosols to other people. So it does protect others, and proper use and compliance does provide protection of the actual user from exposure to respiratory aerosols. Community protective equipment, on the other hand, things like fabric face masks and bandanas, don't have fit testing requirements. They are not personal protective equipment, but they do provide some amount of source control, thereby decreasing the probability of transmission. But it is very important to note that they are not a functional barrier between exposure in the environment and the respiratory system of a potential receptor. So I just kind of want to circle back to the initial health risk or occupational health risk assessment framework to just reaffirm the idea that we don't need to reinvent the wheel. in terms of exposure mitigation for aerosols in occupational settings. We have a lot of excellent tools and a whole lot of research and understanding of actually how to go about that. And that we don't want personal protective equipment to be our first line of defense. We want to manage and engineer the environment and manage the way that people interact with that environment. So finally, I just want to show a couple of resources. The training here on the left is from the World Health Organization. This is a multi-module training that has a really nice Excel-based calculator that allows you to do risk assessments for COVID transmission in mass gatherings. One is a generic assessment, one is for sports and another for religious gatherings, but these could easily be tailored to evaluate risk potentials associated with mass vaccination sites. And on the right here, this is just a call out for various COVID-19 resources associated with the American Industrial Hygiene Association, NIOSH, the National Institutes of Occupational Safety and Health, which has the Engineering Controls Database. NIEHS, which is the National Institutes of Environmental Health Sciences, has the Worker Training Program, which has both the COVID toolkit and the modules on building programs to protect workers from COVID-19. And we also have a approved list of biocidal disinfectants, which is list in from the US EPA. So with that, I want to wrap up. I know I threw a lot of information at you really quickly, but if you have questions, please let us know.
All right, Dr. Wilson, thank you. I think we're going to let Lena just take over. Dr. Moses, if we can have you start sharing your screen, and we will capture all questions in the chat box or in the Q&A section as we go forward. Oh, you're on mute, Dr. Moses.
All right, sorry about that. This is par for the course, I think, with the way that we're living now. So thanks for inviting me here, and I'm going to take a different slant, I think, from the approach that approaches throughout this webinar series, to kind of take a look at what's happening first in the origins and how that impacts exposure, the origins of SARS-CoV-2, as well as looking at the outdoor environment and how it drives transmission with COVID-19. So first of all, I wanted to introduce this One Health approach or concept. A One Health approach is really just the recognition that human health is closely tied and related to animal health and environmental health. So this is really not a field or a specialty, but it's more of just a recognizing that these interactions exist. And I think one of the other things that a One Health approach does is it brings on multi-sectoral, so veterinary health, wildlife health, but everything that encompasses environmental health and safety as well, in a very transdisciplinary and systems-based way. So wanted to take a look at this from the lens of One Health and bring this to the webinar. So I think a lot of times when we think about One Health, we automatically associate it with a zoonotic disease or spillover, which is something that I study and I specialize in. But there's so much more to that that drives disease transmission, disease emergence, and results in something like a large scale pandemic like we're living through right now. So I'm going to touch on the animal origins, and then also talk a little bit about SARS-CoV-2, the virus itself, as an anthroponosis. And so for some of you who are not familiar with that phrase, it's basically any kind of biological microbe that is transmitted from humans to animals and causes disease in animals. So we've talked a lot about this in terms of transmission in and between companion animals after they've acquired it from their owners, but there's also transmission to livestock as well. That's a factor. And then I think one of the things that really sometimes gets missed is all the environmental factors that drive disease emergence and also disease transmission. And it is this multi-pronged direct and indirect interaction. So a lot of environmental factors can actually alter humans to make them more susceptible to infection. They can alter pathogens as well, and we can have impact on the environment. For example, the lockdown measures have had a huge impact on when they were occurring on outdoor air quality. So we have a lot of different interactions that occur. And once you factor in and approach it from a One Health perspective, you start to capture all of these drivers, causal effects, and impacts in a much more holistic way. So I want to start with the animal origins of SARS-CoV-2. I think this is something that is kind of a sexy, exciting area that not just for COVID-19, but for a lot of other diseases that emerge from very exotic places and from very exotic animals. But there's a process that has to happen in order to go from a pathogen that you find only in an animal population that's often unknown to humans to begin with, all the way up to broad scale epidemic spread. So if you take a look at this pyramid here, level 1 is just exposure. You have to come in contact with this pathogen, which means that for any kind of animal-borne disease, you have to come in contact with that animal, either directly or indirectly through body fluids. So this is the origins, at least as far as we believe, of SARS-CoV-2. Maybe there was only one spillover event, but it was enough to actually start and initiate this huge pandemic. So after that, though, there's a in order to actually become a pandemic or epidemic. So that pathogen that is adapted to a different animal species has to be able to infect a human. And actually much of this is biological in terms of capacity, human susceptibility, but sometimes we give Mother Nature a hand with some of sometimes with biosafety issues where we're not needle sticks and things like that can help to drive some of this ability to infect. Once the pathogen gets into a human being and is able to replicate in there, the next hurdle is to actually exit that human being. And so that moves it up and bumps it up to level 3, which is actually being able to transmit to another person. That microbe must be able to exit the human and find another human host and be able to infect them. So once again, there's fewer and fewer pathogens that are able to do this very effectively. And then the fourth level is actually being able to spread rapidly through a broad population. So we're often talking about the reproductive rate, or R naught. So what we need here is an R naught value of above 1 in order to cause epidemic spread. So a lot of the times with infection prevention and control, even when we're focused on preventing spillovers from animals to humans, what we're focused on there is level 1, like just preventing the contact, right, the exposure. And so when you look at this from SARS-CoV-2, a lot of talk has been focused on bats. And it's been identified that horseshoe bats have been implicated in a very similar pandemic, much fewer numbers, but definitely a pandemic in and of itself in 2003 with another coronavirus that caused sudden acute respiratory syndrome. With COVID-19, it's starting to look like there are bats that are implicated, possibilities there, but it looks like this might have been fueled also by the interactions of bats and other animals, maybe an intermediate host in live animal markets. So a lot of the focus, lessons learned from SARS, is really trying to prevent this interaction and this exposure in live animal markets. When you look at this, the hierarchy of control, the options for trying to prevent this is just eliminating any kind of live animal market or any dietary sources that are animal-based, right? So plant-based diet, we can try to implement that across the world to prevent the next pandemic, but it's highly unlikely that that will happen. The other thing is to just ban consumption of wild animals. And China has done this to varying degrees. They've banned specific species. They've tried to ban bat consumption completely. And, when you think about this, there's a huge cultural driver. There are a lot of people that are grounded in hunting, subsistence hunting even, and then there's also a market for that. So trying to ban this without any kind of support is very difficult to do. One of the other things that I really want to try to emphasize here is that oftentimes in the US, when we talk about consumption of wild animals, we call it game hunting, right? But often when it occurs outside of the US with other people and other countries and other cultures, we often call it bushmeat, right? And so it's really the same thing. And so keeping that in mind and the cultural biases that we have towards consumption of animals in other areas is a really, I think we need to check ourselves in terms of cultural elitism here. So a lot of animals are consumed not just because of preference, but because of food security. One of the diseases that I study is a disease called Lassa fever, and it's transmitted by rats. And the biggest driver of this is consumption of rodents. And if you look at protein consumption in these areas, sometimes 40 to 50% or upwards of that protein sources come from rodents. So if you were to ban that, you would actually create an even larger health issue in terms of food security and malnutrition. So when we're talking about this, we have to think about a lot of the knock-on impacts of what we're doing. The other alternative here is to substitute wild live animal markets with something like refrigeration, right? So one of the things that we have to understand, though, is that in the US and in many other areas, we have the resources to enforce food safety, to provide refrigeration all along that food value chain, that agricultural value chain. And what you're doing with that refrigeration and proper butchering practices and food safety adoption is really eliminating some much bigger threats, right? So Salmonella staph, E. coli, there are many, many diseases that if you removed and banned live animal markets without this support for food safety and refrigeration, we would be much more susceptible to many, many other diseases. So moving along here, when you think about this, moving on from the animal origins, when we think about SARS-CoV-2 as an anthropognosis, there have been many documented cases of dogs being infected, cat-to-cat transmission. And although we don't think that it is a big driver of COVID-19 and SARS-CoV-2 transmission, there are some things to keep in mind. So the CDC, I think, has an excellent website on that as a source, both for livestock and for companion animals. Some of you may have been paying attention to what was happening in Denmark with mink farms and the infection of a mink farm in Denmark, adaptation to the minks, and then spillover back with a new variant into the Danish population. And so All of these things need to be considered when we're thinking about controlling, mitigating, and stopping SARS-CoV-2. If we're going to go into environmental factors, with some of the things that I think many people are familiar with, I'm not going to go into too much. I'm not going to touch on the environmental health hazards that actually impair immune response. That could be a completely different seminar all in of itself, and I'm definitely not an expert at that. But definitely there are environmental health hazards that will impair and increase an individual's susceptibility to a microbe and microbial infection and microbial disease severity. Also, food and water security, probably beyond the scope of infection prevention and control and the topics of this webinar, but really some of the things that we've been doing in terms of mitigation and control have impacted people's livelihoods. We've all seen how poverty and inequality have really impacted who gets infected and who dies from COVID-19. But one of the things I want to talk about a little bit is the indoor aspects, or the outdoor aspects of this COVID-19 transmission and disease, as well as climate and what we know so far. Definitely, what we're seeing is that air quality, outdoor air quality, increases likelihood of people dying from COVID-19, maybe not necessarily getting infected with it, but definitely disease severity is tied into this. So what we're seeing is that 9 to 11% increase in mortality from COVID-19 for every 1 microgram, sorry, that should be microgram, of cubic meter increase in air pollution. And there are a number of different particles that have been associated with mortality. And many drivers could be because of the direct damage to cilia, but also air pollution can aggravate indirectly pre-existing cardiovascular and respiratory conditions. And we're seeing this not just in urban populations, but in rural populations that have certain industries like hog raising and farming tied into air quality and increased susceptibility to mortality from COVID. The other thing in terms of climate, one thing that we have all noticed is that as temperatures increase, the number of COVID-19 cases reduce. So just a fancy graph to basically demonstrate to you that that's what's going on here. As temperatures increase, the number of cases, and we're talking about millions and millions in these data sets, it declines. So we're still really trying to unpack humidity. It looks like a moderate level of humidity. There's probably can help to drive COVID-19 and SARS-CoV-2 transmission as well, and also UV radiation from the sun. So we're still trying to unpack much of that right now. But I think it's important to keep in mind a lot of these factors I think are often tied and examined from the perspective of environmental stability of the virus itself. But we also need to look, and I think with a One Health approach, we can start to really try to unpack this. It also has all of these climatic factors have an impact on humans too, and their susceptibility. It can have an impact on your lung ecosystem. You know, humidity can have a direct impact on that, whether or not it's more susceptible or receptive to a microbe, but also human behavior, right? When it's cold, we don't go outside. We're in New Orleans, so when it's really hot, we don't go outside either. But this can actually, a lot of these climatic factors can drive human behavior too, and that may increase or decrease risk of transmission. So I think one of the things that I think the potential that we're pulling, if I were to predict what we're going to do from lessons learned from COVID-19, is that we've learned that the social distancing measures, staying at home, having physical distance, restricting large mass gatherings at some point, masking up, and what I'm talking about is those community protective equipment that Dr. Wilson referred to. Good old-fashioned hand hygiene. It's one of the best things you can do behaviorally to prevent disease, and also disinfection. All of these things are driving and reducing COVID-19 disease and transmission, but we're also seeing a dramatic impact on other respiratory diseases. So I think it's a really good opportunity to learn from this to take the things that are driving it and starting to unpack that, and really try to build in some climatic predictors, even like at a very fine scale, almost like we have for air quality alerts for people with respiratory disease, chronic respiratory disease. I can see us starting to develop models and risk assessments for respiratory disease, where maybe at some points for some weeks, the risk because of temperature and humidity and cloud cover, we could see where there would be high SARS-CoV-2 transmission risk, where people adopt more protective behaviors. And when the risk reduces, then we go back to what I dream of as business as usual. So I think that there are some opportunities here that we can learn, and really using that One Health approach can get us ahead of the curve in many, many ways. And I think that's my last slide. So I'll stop my share, and I think we have some time for a Q&A.
Yeah, thank you, Dr. Moses. That was excellent, and Dr. Wilson as well. We are now going to open this up to Q&A, and there are a few questions that have entered the chat box. Pull this up. And I think this one might be a little bit more in your wheelhouse, Dr. Moses. Is there any evidence, or is there any anecdotal or otherwise evidence to suggest that rodent populations in large cities, those with higher rodent populations, as a larger risk factor, such as in New York, for COVID-19 cases?
It's a great question. I really am kind of obsessed with rodent-borne diseases. At this point, we haven't seen any evidence of this, either in association with high rodent infestation and increased COVID-19. It would be very difficult to unpack the socioeconomic associations of both rodents and humans, rodents and disease, if you were to actually find an association between the two. So far, we don't see that rodents, at least in laboratory measures, are effective at transmitting back into humans. So that's something, and that's probably just because the studies haven't been done. If I were to hazard a guess, that's probably not what's driving what's happening in New York right now. So that's, yeah, but great question.
We also had in New Orleans, the rodent population crashed because their primary food source from restaurants and hotels went away. So actually was very effective pest control.
Yeah, we've seen rodent population behavior really transformed in urban areas because of lockdown. It's really interesting.
Yeah, it was a fascinating connection that you also drew with some of the environmental air quality reductions or improvements, I should say, as an indirect relationship there. So another question that came out, so how might we better ourselves taking that spillover conversation, Dr. Moses, and looking at trying to unpack some of those spillover events occurring to help kind of set the foundation for infection prevention itself, and then control measures following, kind of taking a step outside of the traditional IPC box.
Yeah, I think that a lot of this, when we're looking at disease emergence, that emergence from an animal into human populations, that first spillover event, a lot of it is driven by consumption, right? And consuming animals and animal products in ways that there are probably a lot of mitigation measures that we can do that don't interfere with people's livelihoods or their food security. So that's like hand washing, for example, encouraging hand washing, adopting more better butchering practices, so avoiding certain aspects or the gastrointestinal tract and the spinal cord and things like that. There are probably a lot of things that we could be doing to prevent that without that are realistic, right? Because people are going to eat, people need to be nourished, and they're going to continue to do that regardless of any kind of policies or enforcement that we put in place. So I think this goes back to the hierarchy of controls. When we create an environment where individuals are forced to engage in the kinds of behaviors that will protect them, through environmental controls and modification, then I think that's probably one of the best ways that we can do it. So same rules, just applied to a different setting.
Great answer. This was great information. I think we're getting close to our time. It's 12:59. Pretty good timing to our two experts here. Please take a look in the chat box. I see it was posted. The evaluation at the end just got posted again. Please do, as participants, take that evaluation survey for us. And with that, we will end on time and say thank you very much for joining us. Bye.
Okay, I've removed all the attendees. Layla, we can't hear you. I know you're talking. I see the lips moving. Very, very difficult. Layla will email us her thoughts, I'm sure, just as happened last week. You guys did an awesome job. It was great. Lots of good questions, lots of good information. We thank you very much. And if you have any questions or need anything in the meantime, reach out to Layla. She will be glad to help. Thanks, everyone.
Thanks, y'all.
Thanks, everybody.